All right, we have a special thing that we're going to do today. We're
Yeah.
actually teamed up with Tyler Christifulli
Hey
from
guys.
FOAMfrat. Um,
Hey.
we're going to do a class called "What the F Are We Giving?" So let me talk to you about how important this is. It may sound a little weird, and obviously, if you know Fabiano, she's probably already offended, right?
Yeah. Oh, yes. Yes. Yeah.
You came up with the title. You
Of
came up with
course
the
I did.
title. Uh, all about pharmacology in the obstetrics
Yeah.
pre-hospital.
Right. Obstetrics in general is just an awful field to even think about. But then add it in like an emergent situation or involving the pre-hospital, and it's like, you just know like the basics. So I think like probably getting some background is helpful.
Well, when I came by here just a second ago, one of your colleagues, physician in the ER, asked me what we were doing here. I told him we were going to be talking about obstetric pharmacology,
Mhm.
and you should have seen the look on his face. I was like,
Like,
listen,
"Ah!"
listen, we can make it interesting.
Right,
We can make
right.
it interesting.
It's one of
Uh,
those esoteric fields too, where like if you walk in and they're explaining something to you and you don't know exactly the nomenclature or
Right,
like
right,
how
right.
they verbalize things, or you
Yeah.
say something, you say it backwards, or you pronounce something weird, they look at you like you're the dumbest person
I
in the
know.
world because
Don't you
it
know
is
this?
its
Yeah.
own little island in the hospital, and there's
Right.
certain
Yeah.
medications that you see only in that area. And so it's
That's right.
definitely helpful to
Right.
know how to speak the language when you're going in there to not only get the most out of the report, but also not to look like a clown.
Right.
You know, there in your learning studio, there's a section in your OB cult that is all about speaking the language and not looking like a clown. Matter of fact, I have some references within that today, so I hope you feel good about it.
Oh
Uh,
yeah, yeah. Sam
I
did a great job with that. I
oh,
love the way he prefaced that.
it's a great class. I love at the end where they're holding the mag sulfate the whole time. The cult.
Yeah.
So, again, the format of this thing, this is our intro. We're new to this. He's obviously a lot more experience in these online classes that are being built, but obviously, we're going through the intro right now, and then we're going to go into three separate medications
Sure.
that we use pre-hospital.
Sure.
One's going to be oxytocin or pitocin.
Sure.
Are you an oxytocin or a pitocin?
I don't know. I mean, here's the thing. Why we know oxytocin from the EMS side of it, but I'll tell you from being on the patient side of it, it's pitocin, and they all call it pit.
Yeah, that's what I was gonna say. They're like,
Pit.
it's pit. If you're saying oxytocin, you're a noob. You
Yeah.
got to say a pit.
Pit.
Okay. The other thing we're going to talk about mag sulfate.
Yep.
And then finally, I'm going to let you guys do a one that's a drug that's kind of been on the comeback, especially with what we,
COVID.
yeah,
Turbulate.
terbutaline.
Yeah.
Who would have knew that was used for obstetric?
Yeah, they were dusting off some of those old medicines during that pandemic, just trying and trying. So
No nebs, but you can give a little
yeah,
hit
we
of
don't want to
terbutaline.
actually acutely bronchodilate anything.
So let's get started.
All right.
When we come back, we will talk about pitocin or pit.
Pit.
Okay.
Oxytocin is an important neurotransmitter produced in the hypothalamus and released into the bloodstream by the pituitary gland to initiate contractions for childbirth and milk release. The body naturally produces oxytocin, but for some expecting mothers, they need a little extra push. Pitocin is also recommended for maternal conditions requiring delivery like preeclampsia, diabetes, chronic hypertension, and chronic pulmonary disease. Also, fetal conditions that require prompt delivery like isoimmunization, severe intrauterine growth restriction, RH sensitization, premature and prolonged membrane rupture, incomplete and inevitable abortion, and control of postpartum bleeding or hemorrhage should be controlled with pitocins. Patients need to be taught that contractions will start to get more intense after administration of pitocin. It is also a high alert medication, so mom and baby will need to be monitored closely to ensure that there is no toxicity.
All right.
Pitocin, or also known as PIT,
Yes.
in the obstetric world, used for postpartum hemorrhage, right?
And to jumpstart labor.
Okay. Anything else, Tyler? You agree?
Yeah. No, I with my my second, they
Mhm.
actually we had to start pit,
We did
and
too.
it was interesting. I mean, they went in, they started it, and it was like I mean, it was like clockwork. Immediately,
Yeah.
contractions started getting harder,
Yeah.
and they started getting more they just started getting stronger.
Right. And then they come in, they're like, we're going to increase it. You're like, no.
Yeah, exactly.
But yeah.
So gonna go ahead and tell on myself here, be guilty. I am terrible at measuring blood loss. Terrible at measuring blood loss.
Everybody is, dude.
yeah,
Everybody
think
is
so.
sucks at
Yeah.
it.
Yeah.
So 500 to 1,000 mLs is where we start to worry about this, and it becomes significant. And again, I'm gonna pull the trigger much quicker because I'm terrible at measuring blood loss.
Yeah.
I think they look at it as like, how many pads are you soaking through? You know, like
Yes.
that's probably
Yeah.
a better
Yeah.
way
Right.
of looking at it, because I mean, typically the patient's on a mattress, on a sheet, it's going to soak into the mattress or into the sheet, and it's very hard to quantify how much is actually there. So,
I agree with that.
once you're going through 1-2 pads, you definitely need to start thinking about that.
Right.
very good. Very relative to what we.
Yeah.
So let's talk about how much we're going to give. First off, remember each drug that we're going to go through, we're going to talk about the indications, what it's for, what the F are we giving,
Mhm.
and then how much we're giving, and then what happens if it's contraindicated or we give it too fast.
Okay.
Right? So remember that format, because we're going to follow that for each medication that we give from this point on. All right, so we're giving it for postpartum hemorrhage, and you said
But to jumpstart labor.
okay. So when we give this medication, most I've looked at several guidelines, but most guidelines, it looks like they're mixing this Pitocin up in 1,000 bag.
Yeah.
I'm going to refer to it as 1,000 sack right now. I don't want to use bag anymore. All right, they're putting it in a liter sack, and
A liter of cola.
yeah, a liter sack. And they're putting 20 units in to drift this in over how long?
I mean, it depends. It depends on what you're doing. So like they'll start that drip probably low and slow to like start your labor out, or if like you've kind of just paused your labor for a period of time, and then they kind of increase it, kind of like how it depends how the baby's looking. It depends on how you're looking.
10 to 20 minutes is what I see on average. I mean,
You know what? It's interesting. It doesn't seem like it's like a perfect science. They're
No.
looking at the uterine atony, however you would
I had to
say
look
that.
it up. I had to look it up.
Atony.
Yeah,
the uterine
atony, yeah.
atony, and you're feeling it. And if the stomach if the uterus is not contracting, you're just titrating. I mean, you're literally titrating to uterine atony. So, it's
Tyler, can you
not
stop
like
using that term? Just say lack of tone, please.
lack of tone. Yeah, it's too early for these big words. man.
I had to look it up.
Yeah, atony. And if they don't have an IV, you can do 10 units IM.
Or I think it's even up to 20. I've seen
Yeah.
like emergently, and it's interesting. Like OBs they're so weird about stuff. But like I remember when I was on my rotation, and they were like, "Hey, they would show you." Like we had to take it in med school, and we had to take it again as a resident. And I'm an ER doctor, so I'm not gonna repair any of that. But they were like, here's the laceration. This is how to repair it. I was like, like I'm gonna call you about this. But I remember like a postpartum hemorrhage, and they just like shoved that thing in the thigh.
Well,
They just like,
well,
okay.
It's funny that an IM dose has been added to our protocol, and it's 10 units, and it always throws me off, because when you think about an IM dose, you always think about double, right?
Yeah, sure.
And this
sure,
one's half
Sure,
because
yeah,
of
yeah.
how much you dilute it.
Right.
And
Right.
so I asked a guy that, and he thought I was quizzing him, and I was just asking, like I was like, "Hey, why is this?" And he was like, "I'll get back to you." I was like, "No, you don't have to. I just wondered if you knew." And
The nice thing about IM is it's a delay, right? So it's kind of
Right.
like a built-in infusion, and you can even
Sure.
think about it like the combative patient that you need to put down with ketamine, and you give them 300 of ketamine. You don't have to worry about pushing an IM slow, because
Yeah.
it's just going to have a built-in slow absorption.
Yeah.
And so in this case, you may think, well, when would I have a patient who's postpartum hemorrhage and doesn't have an IV? But it's interesting because right now these home births and using a what is it called? Not a doula, but a midwife.
it's
A
basically
midwife doing
right.
everything really natural. You could be called to somebody who's having a baby in the
Oh
back,
yeah.
has
Yes.
no IV in, and this isn't a bad choice to get this on right away
Right.
if you carry it, which I don't think most EMS providers are carrying PIT.
Do y'all have it?
We do.
You're
you
in a
do?
facility. They're in a facility.
We do. We
I
do.
mean, that makes sense, I guess.
Yeah, we
Rock
do.
on, dude.
We do carry it. And so a couple of things about the administration of Pitocin. First off, we're going to go ahead and utilize a fundal massage, obviously,
Yeah.
right? And most providers, I'm going to be honest with you, do not know how to do a fundal massage.
It hurts.
Yeah,
Really bad.
Yeah.
If the patient's not complaining, you're not doing it right.
Those new sims that we have that where they where it actually starts to get hard and have a lack of atony.
Oh my
so
god.
to speak. But yeah, they don't do very well with that. So
No.
obviously doing non-invasive stuff first, but look at this right here. Do not administer prior to the delivery of the placenta as well.
Mhm.
Very important there. Monitor vital signs. Again, I'm going to reference something in one of you guys' educational video. Most of the time when we think about postpartum hemorrhage based off of your maternal emergencies, we're looking at a replenishment of these patients usually get about 8 packed red cells and 6 of FFP.
Why do you think it's asymmetric like that? Like, why is it not 1 to 1 to 1?
Well, at our service, it is. by
Yeah, that's
protocol.
weird. Why
But,
would that be?
It was just I thought that was pretty neat. Is that much volume that we're ending up replacing?
Yeah.
Based
Was
on,
that in Shane's talk?
yes, it was the maternal emergencies, the new one.
Yeah.
Yeah, it was
Yeah,
really good. It was really.
Yeah, I'd have to ask him where because that was from a paper, right? I believe that was from
yeah, yeah.
I wonder, there's got to be a reason.
It was
Yeah.
good though.
Yeah,
I mean, it was
interesting.
good. It was. I mean, it wasn't like a big learning point. It was just like something a takeaway of how much
Yeah.
actual replenishment of
It's a
volume.
lot. It's a lot more than
It's
you think.
interesting too because Pitocin is a naturally occurring hormone, so
Yeah.
like when the baby nurses,
Yeah.
it actually starts to increase the amount of endogenous Pitocin. So
Yeah.
if mom is bleeding, I mean, if the baby's able to, if you start having mom nurse the baby
Sure.
right away, if they can, that can definitely help release like just the intrinsic amount of Pitocin.
Do you know what Pitocin's nickname is? The love hormone. Did you know that? Did you know?
Yeah, I
that?
actually have cologne Pitocin that I spray on the pheromones.
Yeah. So really
I also
quick,
have 3 kids, and that
That's
explains
what I was just
how good it
thinking that.
works.
I'm like, huh.
stay out of my studio. So summing this up right here, 2 main physical functions of Pitocin are to stimulate uterine contractions in labor and childbirth, and to stimulate contractions of the breast tissue to aid in lactation after childbirth. Pitocin also acts as a chemical messenger in the brain, blah, blah, blah.
It allows more like intracellular calcium
Oh yeah.
to contract, so like you think about the things that you need calcium for, like to contract, the beta islet cells to release insulin, or
Yeah, like basically everything. I mean,
the milk. I saw it. Is it the milk alveoli? Is what I was reading. Is with the breast tissue. It's called the
Yeah.
milk alveoli. I was like,
Yeah.
oh man, I've never heard it referred to that as before. But yeah, it makes things contract. It allows more calcium available. So that's something to consider too, because if your patient is bleeding and they are going into hemorrhagic shock, we know you can be hypocalcemic with that as well. So you need calcium in order for Pitocin to work. And so it's not a bad idea to think about if you're coming in late in the game, they may need some calcium as well.
I imagine that most people that are getting these massive transfusions also get calcium. I mean, they're
Yeah.
generally
Yeah, exactly.
And finally, we said we were going to talk about this if there's a contraindication. So what happens when Pitocin levels are too high? Having higher than normal Pitocin levels is very rare for people assigned female at birth and is called Pitocin toxicity.
Who knew?
It results in an overactive uterus, causing an increase in uterine muscle mass, hypertrophy. Thank you. I needed a little help with that this morning, which limits pregnancy due to not being enough space in the uterus to hold your fetus.
So we're really not going to worry about that.
No,
We're not going to make anybody Pitocin
yeah,
toxic.
no, not at all.
I don't think so.
When we come back, we're actually going to talk about what you boys up there in Wisconsin like to call the elixir of life. And we'll go into that.
Miller Lite.
Yep.
Come on down to Uncle Bubba's Garage. We have the largest reliable miscellaneous items for all your needs. Right now, we have a special today on Epsom salt.
Uncle Bubba, what do I need Epsom salt for?
I'm glad you asked, random woman. You can use it for anything and everything. And when I say anything, I mean anything. Achy muscles? Epsom salt. Flu, cold, cancer, allergies, give them Epsom salt. They'll be on the school bus before you can say roll tussle. Epsom salt.
Uncle Bubba's Garage does not own the rights to Epsom salt and is not responsible for any allergic reactions, infections, or diseases caused by it. By
All
Charles.
right.
All right.
So we're back and we're going to go ahead and be discussing what these boys up in Wisconsin call the elixir of life.
Okay.
Magnesium sulfate.
Sure.
I do want to give a little bit of background because I think this is really cool. And I think Sam did a really good job with his class, OB Emergencies, where he introduced the OB cult, talked about learning the language, and then went into alchemy and all that. See, I paid attention.
You did, man. You
Yeah.
watched it a few times. I can tell.
Yes. So he goes in and he tells about how this region finds and discovers magnesium. So then after that, later on, when magnesium sulfate was actually discovered, there was like this trough in the local village, and the horses wouldn't drink out of this trough. And actually, there was like tourists that would come around to watch these horses not drink out of this trough. And I guess it was the maybe calcification of magnesium sulfate. Does that sound accurate?
Yeah.
And then, so then Epsom salt was invented, which is magnesium sulfate.
Oh.
Is that cool?
How many patients have you ever seen that literally have tried Epsom salt for any number of ailments?
Oh,
It's like
yeah.
the answer.
Absolutely.
It's like the answer.
I have a bag of it. I put it in my bathtub and I'll sit in it and just.
They use it for everything, and you're like, huh. So magnesium sulfate actually is like the doctor's go-to answer. Do you know what I'm talking about? Have you
Mhm.
guys tried you guys call about an arrhythmia, you call about a cardiac arrest, you call about a breathing issue, do you think their hypomag is their EKGs weird? Don't we always say that? Isn't that always the doctor's go-to answer? I always say there's like a collection of answers. One of them is potassium, syphilis, the number 5. And have you tried magnesium sulfate? Is the next one. We use it for migraines. We use it for all kinds of stuff. So it's like, that's our go-to.
Well, let's discuss why. All right. So let's break that down. Why it is.
Yeah.
All right. And so when we think about magnesium sulfate with pregnancy, obstetric issues, we think about it in 3 different things to where it can help.
Okay.
One is the fact that it's very useful for eclampsia, preeclampsia that has progressed to eclampsia and has started the seizure activity, or the patient to have a seizure. The other thing is when you give it, it causes vasodilation.
Sure.
Well, what is the key indicator of, or excuse me, what does preeclampsia come with besides being pregnant? Hypertensive.
Sure.
So when you cause vasodilation, you're going to drop
Sure.
the blood. So that's why it's wonderful there. And then finally, it can stop uterine contractions to keep unwanted babies coming. Why would they want unwanted babies? Well, if there's some kind of issue with them being breached or tough delivery,
You're like
and
out to
want them
eat or
be-
something. And
Yeah.
Right.
Yeah, you want to get your money's worth.
yeah.
We're taking magnesium pills.
You're like a Bob Evans or something, and then you're having contractions. You can,
Yeah.
you can
So
delay that.
let's build off of that, and I'm going to allow you guys to jump in really quick. But I do want to talk about this. So when the patient has a seizure, what is the issue? When the patient becomes eclamptic, what is the issue that is causing them to have a seizure?
Yes, I mean, It's multifaceted. So we know that there's hypertension that occurs in that
Right.
preeclampsia phase. And then once they actually go into the seizure, they're, considered eclamptic at that point. And there's a degradation of and breakdown of the blood-brain barrier that will allow certain proteins to cross through that blood-brain barrier, and they can be very toxic to the brain. So magnesium does a couple things. It causes vasodilatory or vasodilation within the cerebral vasculature, but it also has some blood-brain barrier protection mechanisms as well. And so that's why it's like the go-to. However, if somebody is actively seizing when you get there, your first line is still benzos, but you need to think about getting the mag on as soon as possible because it has more effects than just dropping your blood pressure, can actually protect that blood-brain barrier. Calcium is what causes like the contractions and stuff, but there's other actual plasma proteins that can cross in through the blood-brain barrier.
So, and I thought it does something too at the placental level as well. There's a lot of inflammatory stuff going on there when a person is eclamptic, and it helps assist with that as well.
So when we were looking at obviously magnesium sulfate working to work very well with that patient that has become eclamptic, we often think about clogging up that calcium channel, right? Taking mag sulfate and clogging up that calcium channel. Does that sound pretty good far as if you were going to explain to somebody how this worked, or
like blocking it?
Yes.
Yeah, it's to allow smooth muscle relaxation. So when you're given mag for eclampsia, you do get some muscle relaxation. I mean, that's not really the full effect of like stopping the seizure. There's more to that. And like Dr. Fabiano was saying, the body seems to think that it's not perfusing the placenta. And so it keeps like increasing the blood pressure. Increasing it. And as it starts to rise, it starts to break down the blood-brain barrier.
Yeah.
But when we think about mag for like preterm labor, we're giving it to just slow down those contractions to make them not as strong. And we know whenever calcium rushes into a cell, it could cause things to contract, right? So if you give something like magnesium sulfate, magnesium is a molecule that can actually clog up those calcium channels. It's a natural calcium channel blocker. And so you're going to get the things like vasodilation, but you're also going to get some muscle relaxation as well, even slowing down of the heart rate, slowing down over the ventilation, respiratory rate. So it's going to just bring everything and kind of calm it down a little. And typically that's given as like 2 grams that they'll give, or like 2 or 4 grams over 30 minutes. And then they'll do 2 grams as an infusion, like over the
I think even when I was training, like if you were on of course, like you get access and do benzos, but I also heard like you give like the 6 gram slam or the 8 gram slam, and it was like IM injections of mag just up front. I mean, that was like, during the emergency phase of it, obviously. And then that goes right along with that is always a follow-up question of like the mag toxicity. Like they go hand in hand. The next patient, the person has no reflexes or something. What are you supposed to do with that patient, Michael? Do you remember?
So, give calcium.
Yeah.
So let's sum this up really quick. Let's talk about it. So why the F are we giving mag sulfate? So one, we're giving mag sulfate for a patient that has progressed to eclampsia. How is that going to work? It's going to work because it causes some smooth muscle relaxation. It also causes vasodilation for this patient that is extremely hypertensive, that is progressing toward seizure activity. The other thing is, it also has because we've already talked about not allowing the calcium to enter the cell, hopefully keeping unwanted births from happening. Like you said, you're meeting at the what's it called? Meeting at the eating a buffet, right?
Yeah, you're at the buffet. Or Bob Evans, You guys have Bob Evans there?
Yeah, we do actually.
Where? Not anymore.
I don't know.
You know what's interesting is like a lot of times you'll walk in and they'll already have gotten the 4 gram bolus and now they're on the 2 grams an hour. Right. And I think it's important that we keep that going. We're not like, oh, it's, they've already gotten the bolus, kind of like you do with like heparin on a STEMI, like, oh, they're just on 1,000 hour of heparin. Like you want to keep them at that therapeutic mag levels, and you'll see they'll push the mag levels pretty high on these patients. Like you can see them like sometimes 5 or 6 to try to prevent those contractions. But what's really interesting is like if you take a patient that is preterm and they're trying to avoid them, going into delivery until they get to a facility that has a NICU. If it's, inevitable, they're going to have it, so throughout the transport, they're trying to slow down the contractions, make them not as strong. But if that same patient, after they deliver the baby, goes into postpartum hemorrhage, everything you've done to prevent that baby from coming out
Now you
starts
gotta
to work
reverse it.
against you. when it
Right.
comes
Now you got to
to
reverse it.
the bleed. Yeah. So then you have to go back and you have to try to reverse it all. So, if you think the delivery is inevitable and you're like, oh man, it's coming right now, like I can see baby, it doesn't make sense to be like, okay, let's push mag right now. It's like that baby's coming out no matter what right now.
Actually, I don't think we do have a Bob Evans. We just have the mashed potatoes.
That's where your mind
That's
goes.
all you got out of that, what I just said? You're still stuck on the Bob.
That's all you have to say.
I'm sorry, but I was like
Very focused on that part of it.
Yeah, but obviously I heard him. He said at that point in time, it's not important to push the mag. The baby's coming already. I heard it.
Yeah. If you can see the little top of baby's head and stuff, and you're like, oh, it's coming right now. It's not that you're expecting them to have postpartum hemorrhage, but it's always a possibility. And at that point, it's not like the mag's going to kick in and the kid's just going to be chilling in the vaginal canal for the rest of your transport.
Right. Yeah, that's right. That's right.
So what if we give too much? There's a thing called mag toxicity.
Yes.
The biggest problem with mag toxicity is the respiratory depression.
Right.
And you guys carry reflex hammers too, right? So you can check their deep tendon reflexes.
Right.
Right
here.
Yeah. It's a reflex hammer.
True story. I used to carry one with me. And I would hold that at all. I would hold the arm and hit it like right here on the arm and see if I could make like the radial or ulnar, I should say, reflex. It turns out you can just say squeeze my fingers. And that's not a bad thing to do. So, can you squeeze my fingers? All right, because you will start losing your DTRs probably before you start seeing some of the other stuff. So, check in to make sure they can squeeze your fingers. Make sure you're not just slamming it. I definitely recommend this goes on a pump. I think that if you're going to be running 2 grams over an hour, why take them off a pump at the hospital and then just cowboy it, in the field? And I think it makes sense to have it on a pump and as controlled as possible, not only to avoid giving too much, but also if it kinks, you're not giving it, so it alarms and lets you know as well.
I carry a deep tendon reflex hammer too. It's got Husky on the side. So Tyler, when we come back, we're going to be talking about terbutaline, and I'm going to be honest with you. I'm going to let you and Fabiano kind of take this one over. Is there anything else that we need to talk about with mag sulfate?
No, but that's why it works for bronchodilation. That's why it works for migraines. All the same thing.
AFib RVR.
Calling all women. Did you know a birth control pill does not need estrogen to prevent pregnancy? Slind birth control is over 98% effective and is estrogen-free. So if you're interested in avoiding unnecessary hormones, or you have a health reason to steer clear of estrogen, it's time to say goodbye to estrogen and hello to Slind. Hello to a flexible window to catch up on a missed pill, and hello to periods on a schedule. Do not take Slind if you have kidney problems, reduced adrenal gland function, cervical cancer, or any hormone-sensitive cancer, liver disease, or unexplained vaginal bleeding. If these happen with Slind, stop and call your doctor. Before taking Slind, tell your doctor if you may be pregnant or have had blood clots, stroke, heart attack, high potassium in your blood, diabetes, or depression, which can lead to possible serious side effects. Say goodbye to estrogen and hello to Slind. Talk to your doctor about Slind today.
Now that we're back, we're going to finally discuss terbutaline, and I'm going to let you guys have at it. You got 5 minutes.
Okay. So interestingly, terbutaline's been around forever, and there's a PO dose, of course, that you've seen some like old school COPD patients on, asthma patients that are refractory, and then you see like the sub-Q and the IV stuff. It came back in vogue with the respiratory part with COVID. I don't know, plus or minus what you've seen from that. You give 0.25 usually sub-Q, and then it takes about I read it takes like 30 to 60 minutes to take effect. Well, really, in the EMS world, that's too long. I hate to say it's too long. It's really too long for anybody. But I'm like, oh, by the time they get here, it'll so good. I mean, we give steroids and they don't do anything right away either. But anyway, from the preterm labor aspect of it, it would be like 2.5 to 5 IV, and some people can even be on an infusion, which is not common. It's not common. But and I don't know what your experience is in the field, Tyler. I'd love to hear it. But they primarily, it acts similar to other things that we talk about in that it kind of sucks up the calcium. There's like an enzyme release and it kind of sucks out the calcium so that there's no like actin and myosin bridge. So there's no contraction, of the contractions slow down. But I'd love to hear about what you've had experience wise.
Yeah, so terbutaline is the drug that I always ask if they gave to make it sound like I know what I'm doing when I'm getting ready.
Right. Yes.
So they'll be like, yeah, we got them on MAG. They got 4 as a bolus, 2. We gave indomethacin. And I'll be like, did you guys give any terbutaline? And then they'll be like, oh, you know what? No, we didn't. We can give some for transport. I'm like, yeah, you're going to want that terbutaline. It's what's interesting. The most fascinating thing about terbutaline to me is if you look up the molecular structure of epi and terbutaline, they're almost identical. They're almost like
completely talked about that online. I was reading that. I'm like,
there's only like one little thing that's like different, right. And I can't remember what it is, like a polymer or something like that. But there's like one thing that's different. So you get a lot of the same effects as epi, and epi is actually considered a tocolytic as well, which I don't think anybody in their right mind would give epi to slow down contractions, but it works the same way, except terbutaline and epi, I should say, but terbutaline is not going to raise the heart rate as much, but you definitely do get a bump in heart rate and even blood pressure for that matter. So if somebody is preeclamptic and they're preterm and you're thinking maybe it's a smart idea to give them some terbutaline, I'd probably say stick with MAG at that point because you're going to get a bump in that blood pressure for sure. So
and I think I'd only want you to use it if it's above 120.
Yeah.
From a heart rate perspective, I find that interesting because I feel like most people we saw during COVID, I know that I'm not really saying that correctly. The first round of COVID, let me put it that way.
We were all guessing.
Everybody's heart rate was like 140 because they're breathing like 55 breaths a minute, and I'm like, okay, here, let me give you this. I'm not going to give you this albuterol that I like directly. I use terbutaline, but that's interesting. Have you transported anybody with terbutaline?
Reactive airway.
No. Kind
of a throw the kitchen sink at them.
Yeah.
Actually, when we're thinking about this, we have talked about terbutaline coming back into favor before, but when Tyler made the recommendation of terbutaline as well,
You wanted to run away screaming?
No, I forgot.
You did.
Well, it's probably already given by the time that you get there. They already got
it.
And
if not, you definitely, that's your question. Like, that's your go-to. That like 5 is my go-to.
And I remember saying,
right.
I remember like, oh, did you guys give that IV? And like, then I automatically looked like an idiot because they're like, oh, no, that goes sub-Q. And I'm like, man, I just sold myself out that I don't know anything about this drug. So
it's give an IV, but it would be on an infusion.
It's like a drip if it's IV, right?
Yeah.
That's what you were talking about.
That's what I was saying. Yeah, it's most of it's sub-Q. You're correct. And then they talk about off-label. It's actually off-label for preterm label. 2.5 to 5 mics per minute IV.
Really quick, guys, because we only have 1 more minute. What happens if you give too much?
Too much terbutaline?
Mm-hmm.
Heart rate jumps up, blood pressure goes up.
Tacky.
Yeah.
Okay.
Too much smooth muscle relaxation.
Sure.
So I'm going to read this.
The baby just falls out.
So I'm going to read this really quick. I highlighted this, and this is oxytocin in people assigned male at birth. In people assigned male at birth, oxytocin plays a part in ejaculation.
Great way to round that one out.
Thank you.
Yeah, I thought it was good. So Tyler, I do want to thank you for doing this with us.
Yeah, absolutely, man. Absolutely.
So fun.
Do you want to come back and talk about TXA, or do you want to save that for another one?
I'd love to come back.
I think we should do a TXA, like all uses of TXA.
Yeah.
Right.
Let's come back and talk about TXA.
Let's do it.
All right, we're back. Finish this whole episode up. We want to talk about something that's a little maybe controversial right here, and that's the use of TXA in our pregnant patients.
So I don't know. This is so controversial, even with trauma and la-di-la, what all the uses for it. to me, if it's a postpartum hemorrhage, you're doing all the other stuff, and this is like life threatening, you give it. That's what I think. I don't know if that's
I agree. Totally. I mean, there was the woman trial that came out. It was in a third world country though. So everybody was like, how much of this data can we actually extrapolate to us here in the US? But, we give TXA to prevent the fibrinolytic activity. So the body wants to start breaking down the clot after it's formed. And if it's breaking that clot down too early, then obviously that's going to cause increased bleeding. And so they looked at pregnant women and they looked at a thromboelastogram or a TEG, which I don't know if Prisma, if you guys, I know in the ambulance you don't, but I'm sure in the hospital they probably
have a TEG. Yeah.
Yeah. They'll look at the fibrinolysis at 30 minutes and you can, it's like the end of it where you'll see it like turn into like this tiny little like line and they'll see it's breaking that clot down too early. I agree with the doc here that if you are giving all the other things and there's postpartum hemorrhage, I think we have enough evidence to say that go ahead and try it. I mean, it's not like it's the amount of it that actually crosses over into like breast milk is really small. It's probably not going to have any bad effects, which is what the woman trial showed. So the question is it going to help or not? And I don't think you really have to worry about any of the side effects. You're given a gram. If they're continuously bleeding, sometimes you'll see them give an infusion as well on top of that. Yeah. But yeah, I definitely think it's worth throwing it in. Give a gram of TXA. Typically, you'll see it over 10 to 20 minutes. I think most people are putting it in a syringe and just giving it as a slow IV push. But you also have to think about if they're bleeding, if you're pushing it, you're going to bleed. I don't want to say you're going to bleed it out right away, but it's going to end up eventually leaving. So I do think an infusion makes sense. I'm not as picky about putting this one on the pump. I'll put 1,000 grams into like a 50 ml bag, hang it, and just let it run in over gravity.
Yeah. And a lot of people are moving towards the 2 gram. I don't know how OB thinks about that. I guess we'll have to ask them to kind of pick their brain about that stuff. The other thing I know that, what kept a lot of trauma people from using it was the pro clot thing. And, pregnant people are already at risk for DVTs and PEs in general. But I think if somebody's dying in front of you, you don't really have an option.
Yeah, no, I totally agree. It's the prevent. I think understanding how TXA works is so important because then you can maybe get a little bit more granular on who you give it to. And so it's not like it's going to make them clot easier. It's just maybe not going to break down their clots if you give that. And so the evidence is, they looked at the crash something study, crash 2, I think was the last one. And they looked at head bleeds and they found like there was a very specific GCS population, like not the horrible ones, not the ones that are going to get discharged, but like that middle ground where maybe there's some benefit to it. So the literature's not the best, but I think best practice, I think most people right now are still doing it for postpartum hemorrhage.
Yeah.
Always follow your local guidelines, though. Always follow your local.
Hey, look who's calling me. Old Vinny Patel.
All right,
put him on the podcast.
Right, sure.
You can. But so we do appreciate you helping us today break down this not so interesting topic. We'll sum up what the F are we giving just by having a good time and just say thank you for our viewers.
Yep. Yeah, so nice to meet the famous Dr. Fabiano.
Oh yeah, just call me Sarah. Yeah, thanks. Good to meet you officially.
Awesome. Thanks, guys.
All right.
Yep.
Bye.
Bye-bye.